Welcome back to the deep dive. Today, we're diving deep into a specific medical condition using a stack of revision notes as our guide. Think of this as us stripping away the extra stuff, really getting straight to the high yield core. Perfect if you're consolidating knowledge.
That's exactly right. Our mission here is to take these notes on Alport syndrome and just boil them down, cut through to what truly matters for understanding and, yeah, for revision. We want you to walk away with a really crystal clear grasp of the essential facts and, maybe more importantly, how they all connect.
Alport syndrome. Okay, maybe you know the name, maybe it's totally new territory for you, but these notes describe a condition with, like, a single underlying flaw causing problems all over. What's the very first thing that jumps out at you when you look at how it's defined here?
Well, what's immediately striking, and it's really the central theme, isn't it? Alport's is fundamentally a genetic disorder. It's rooted in a defect in type 5V collagen. And this isn't just any collagen. Type 5 is absolutely critical for the structural integrity of basement membranes.
Basement membranes, right.
Yeah, and where do these notes say they're vital? In the kidneys, the ears, and the eyes. That single connection, that's the key. It explains why these three seemingly unrelated systems on the main ones hit. The notes also make sure to highlight the different inheritance patterns right away, which tells you it's not quite a simple one-size-fits-all genetic story.
Okay, so it's genetic, it messes with type 5e collagen, and it targets kidneys, ears, and eyes because that specific collagen is crucial in their basement membranes. That connection feels really central. Beyond that baseline, what are the absolute non-negotiable characteristics these notes flag for us in the definition and those key points sections?
Right. If you remember nothing else in the definition, you've got to remember the triad, progressive kidney disease, sensorineural hearing loss, and ocular abnormalities, eye problems. The notes are very clear. The cause traces back to mutations in the CL4A genes. Those are basically the instructions for building type 5e collagen. And those key points, they're practically screaming, memorize this. They reinforce that triad and crucially state that the disease will progress. It leads to end-stage kidney disease, ESKD. Pathologically, the really defining feature in the kidney is this irregular thickening, thinning, and very distinct splitting of the glomerular basement membrane, the GBM.
Splitting.
Yeah, splitting is a hallmark. It's the structural failure from the faulty collagen that drives the progression to ESKD.
So we know what it is, and the main players, faulty type 4 collagen, kidney, ear, eye. Let's dig into the why now, the etiology and pathophysiology. Why does this actually happen?
Yeah, it takes us right back to that core concept again.
Yeah.
The etiology, the cause, is genetically simple. Mutations in CL4A3, CL4A4, or CL4A5, the genes for type 4 collagen. The pathophysiology is just the sequence of events that unfolds because the collagen's abnormal. Defective collagen means defective basement membranes, particularly in those high-stress areas like the kidney filters and the delicate structures in the ear and eye.
And how does a defective basement membrane in the kidney, for example, actually cause the problems, like the progressive kidney disease?
Well, the notes paint a picture of dysfunction, really. Because the main type 5V collagen isn't working right, the body kind of tries to compensate. The source mentions an accumulation of other collagen types, specifically V and CI in the GBM.
Okay, like trying to patch it up.
Exactly. But this attempt to patch things up actually leads to abnormal thickening, and it also ruins the membrane's main job. It loses its selectivity. So instead of filtering neatly, it gets leaky and eventually scarred. That's the glomerular sclerosis and interstitial fibrosis the notes talk about.
Ah, I see.
It's a bit like, trying to rebuild a vital structural wall with the wrong kind of bricks. The whole structure, the kidney's filtering ability, eventually fails, leads to CKD.
That makes total sense. One faulty building block triggers this collapse in specific spots. Now, the notes also throw in an association that sounds quite different. Alport syndrome with leiomyomatosis. What's that about, based on these notes?
Yeah, this is mentioned as a distinct form, kind of a subtype. According to the source, it's characterized by leiomyomas. Those are benign, smooth muscle tumors. And critically, they show up in the esophagus and the tracheobronchial tree, so their airway and swallowing tube.
Okay.
The notes list the symptoms you'd expect from them: trouble breathing, dyspnea, cough, difficulty swallowing, dysphagia, things like that. Diagnosis is usually via imaging, CT, or MRI. It's an important association to just be aware of. Maybe less common than the core triad, but it's directly linked in these notes.
Right. Good flag. Moving on then, who typically gets this? Who's affected by Alports and what are the risk factors? The epidemiology section gives some numbers.
Yeah, for the UK, the prevalence is estimated in the notes as roughly 1 in 5,000 to 1 in 10,000 people. A really key point for revision here is the gender difference they highlight. The disease is usually much more severe in males. Females often have milder symptoms and rarely progress to actual renal failure, though they can definitely be carriers. And these notes also point out its significance in childhood ESKD. It apparently accounts for about 3% of those cases.
We mentioned inheritance patterns earlier. How does the epidemiology section break those down percentage-wise?
Right, this is crucial for understanding the risk. The notes state X-linked dominant is the most common pattern by far, about 85% of cases.
85%. Wow.
Yeah. Then autosomal recessive accounts for maybe 15%, and autosomal dominant is pretty rare, only about 1%. So this really confirms that X-linked is the main way it's inherited that you'll likely encounter. And here's a fascinating detail they mention. Up to 20% of cases are from spontaneous mutations, de novo mutations,
Yeah.
meaning there might be absolutely no prior family history.
That spontaneous mutation point is huge, isn't it? So while family history is obviously the primary risk factor you'd look for, its absence doesn't rule Alports out at all.
Exactly right. You can't just assume it's always passed down from a known affected family member. 20% is quite significant.
Okay, so if you're seeing someone maybe in clinic and Alports is on your differential list, what are the clinical features you'd actually be looking for according to these notes? What does it look like?
Again, it comes back to that core triad as the foundation. Hematuria blood in the urine. Often that's the very first sign, especially microscopic hematuria that you only pick up on tests.
Right.
Then the progressive chronic kidney disease, the sensorineural hearing loss, and those eye abnormalities. The notes confirm that progression to ESKD is the typical outcome. Onset is usually in childhood. And they also mention proteinuria protein in the urine is extremely common, found in like 85–95% of patients.
What specific things might you see wrong with the eyes?
The notes list several specific findings: cataracts, microspherophakia, that's an abnormally small spherical lens,
Okay.
and both posterior or anterior lenticonus.
Mm.
That's basically a cone-shaped bulge on the back or front surface of the lens. The notes describe the vision deterioration as typically slow and progressive.
And looping back to the kidney for diagnosis, the notes really stress the importance of the renal biopsy findings again here. What's the critical feature to spot on that biopsy?
The absolute diagnostic hallmark, mentioned repeatedly, is lamina densa splitting on the electron microscopy of the renal biopsy. This distinctive look of the GBM, like it's splitting into layers, that's key. The notes also add an interesting correlation. Mutations located towards the 5-foot end of the gene seem to be linked with symptoms starting earlier in life.
Okay, that's a useful detail. So given this unique mix of symptoms, kidney, ear, eye, what else could potentially look like Alports? What's on the differential diagnosis list?
Yeah, the notes approach this logically. You basically need to think about other conditions that share some of these features, other things that cause CKD plus hearing loss or CKD plus eye problems. The source specifically mentions certain types of glomerulonephritis, other kidney diseases, and also other genetic syndromes as possibilities. The job really is using investigations to sort through those possibilities.
Which brings us to investigations. How do you definitively confirm a suspected case based on these notes?
Right. The notes outline the pathway. You'd start with the basics: urine tests, looking for that blood and protein; kidney function tests to see how well they're working; hearing tests, obviously; and ophthalmological exams to check the eyes thoroughly.
Standard workup, but for confirmation.
Exactly. For the definitive diagnosis, the gold standard tests listed are molecular genetic testing, actually finding the specific mutation in one of those COL4A genes, and that crucial renal biopsy, specifically looking for the lamina densa splitting and other changes under the microscope. The notes also mention, interestingly, that in some cases, a gingival biopsy, a gum biopsy, can sometimes be used. Less common, but it's noted here as an option.
Okay. So once you have a confirmed diagnosis, what does management involve? The notes are pretty blunt, saying there's no definitive treatment available.
Yeah, that statement really sets the scene, doesn't it? Since we can't fix the underlying genetic problem, the management described focuses entirely on supportive care, symptom control, trying to slow down the progression and improve quality of life. The notes list the key strategies: rigorous monitoring of kidney function, very strict blood pressure control, treating any UTIs promptly, addressing the hearing loss with aids or even cochlear implants, and regular eye checkups.
And what happens when kidney function really starts to decline significantly?
Then the notes move into renal replacement therapy, so either dialysis or ideally kidney transplantation. They highlight that transplantation is generally pretty successful. High graft survival rates are mentioned. However, there's that small noted risk, about 1–5% of developing something called anti-GBM nephritis after the transplant.
Anti-GBM nephritis.
Yeah, it's an immune reaction against the new kidney's basement membrane collagen, a potential complication to be aware of post-transplant.
Got it. The notes put a lot of emphasis on blood pressure control and certain meds. What's the key takeaway there?
Hypertension, high blood pressure, is a really major factor in Alports, especially in males and the more severe forms, and it definitely gets worse as the kidney disease progresses. The notes specifically call out ACE inhibitors. These drugs reduce the proteinuria, the protein leaking into the urine, and crucially, they've been shown to slow down the progression of the actual kidney disease.
Right, so they're protective.
Exactly. The recommendation is to consider them, especially in children who already have proteinuria. There's also mention that sometimes adding spironolactone to the ACE inhibitor can lead to further significant reductions in proteinuria.
And genetic counseling is also listed. Why is that so important here?
Well, given it's a genetic disorder with those different inheritance patterns we talked about, understanding the risk for other family members, siblings, parents, potentially future children is vital. Genetic counseling helps families navigate all of that.
Makes sense.
The notes also bring up the point about incomplete penetrance in females, where they might carry the gene but have very mild or even no symptoms. And they note that genetic tests are getting much better at identifying carriers accurately.
Right. And finally, the prognosis. What does the typical outlook look like for someone with Alports, according to this material?
The notes stress it's variable. It really depends on the inheritance pattern, the person's sex, and even the specific CO4A mutation they have. But they do reiterate the most common outcome. Males with the X-linked form usually progress to ESKD, often relatively early in life. There's also a specific note that pregnancy can unfortunately worsen kidney disease, so managing pregnancy requires really careful planning and monitoring.
Okay. So what are the main potential complications someone with Alports might face down the line, as listed in these notes?
Well, as the disease progresses, the complications are really direct consequences of that organ damage. The notes clearly list chronic kidney, whereas nephrotic syndrome is really defined by massive protein loss in the urine, which leads to widespread swelling, edema, low protein levels in the blood, hypoalbuminemia, and high cholesterol or fats in the blood, hyperlipidemia. They're just distinct clinical pictures of kidney dysfunction you might see.
Okay, that was a really comprehensive sweep through these revision notes, packed with detail, but definitely framed for high-yield revision, which was the goal. Now, these notes mention using mnemonics or memory aids. They don't give specific ones, but let's quickly pull out some of the absolute highest yield facts we've covered, the kind of things perfect for building memory hooks around.
Great idea. Thinking about what's most testable or just crucial for quick recall. Definitely that core triad, kidney, ear, eye. Maybe just key. Think can't see, can't pee, can't hear a high C. A bit old school, but memorable. Then the specific defect. Type 5e collagen and those COL4A genes, 3, 4, 5. The most common inheritance. X-linked dominant. Remember that 85%. The key diagnostic biopsy finding. That lamina densa splitting. Super specific. And for management, you need to remember it's supportive, but particularly ACE inhibitors for the proteinuria. That age range for ESKD in males, maybe 16 to 37, that's also a pretty high-yield detail to have in your back pocket.
Right. And you can see how an exam question would be built around these, like a 17-year-old male presents with persistent microscopic hematuria and recently diagnosed high-frequency hearing loss. A renal biopsy shows characteristic splitting of the glomerular basement membrane. Which protein is most likely defective?
Exactly. That combo points straight to type of E collagen because of the kidney, ear, and specific biopsy finding. You've linked the key features.
Or maybe, which inheritance pattern accounts for the majority of Alport syndrome cases, and how does disease severity typically differ between sexes?
Yeah, that tests the epidemiology, the 85% X-linked dominant, and that crucial point about males usually being more severely affected. The key really is connecting that initial collagen flaw to the specific damage locations, kidney, ear, eye, and then remembering the patterns of inheritance and progression.
Wow, okay. We've really managed to distill these notes on Alport syndrome, haven't we? From that fundamental genetic defect in type 5 collagen and how it hits the basement membranes in the kidney, ear, and eye, all the way through the clinical picture, how you diagnose it, manage it supportively, and the potential complications.
Yeah, and understanding that single root cause, the type 5e collagen defect, really is the thread that ties it all together, ties together those diverse symptoms in the kidney, ear, and eye, It's a powerful example of how critical these structural components are.
Absolutely. Really highlights the interconnectedness. So thinking about it all, what's maybe the one thing that stands out to you after going through these notes? Something for you, the listener, to keep mulling over. Maybe it's that surprising rate of spontaneous mutations, or just how that single defect plays out so differently across those three organs.
Yeah, thinking critically about how these pieces fit and maybe how you test your own understanding of it. That's what really makes this knowledge stick for revision, isn't it?
Definitely. So if you are getting ready for exams like the MSRA or just want more ways to test yourself on this and other topics, do check out passthemsra.com.
And for loads more free resources to help you out with your revision journey, head over to freemsra.com.
That wraps up this deep dive on Alport syndrome. We really hope it's been a valuable revision boost for you.